So thank you very much. I want to add one other thank you. I'm not sure I'll be speaking about leadership. I have this very broad mandate here, but I do want to say something about leadership that we're seeing here today. One of the pillars, or two of the pillars in my view, of successful advocacy, one is the empowered patient, that when you reach the patient and put them at the center. The other is when you have the clinician who has had either a conversion experience or the clinician who can speak with authority from that role about a broad public health and policy issue. And I think we're very fortunate to also be here with the head of the London School, who is a known authority and leader in AIDS, talking about NCDs being such a huge priority. I think that makes a tremendous difference. And people like Sally, who came from the AIDS world as well, now saying, this is the next big priority. So thank you. It's an honor and a pleasure to be here today. Thanks to everybody for organizing this, Pablo and Neil in particular. I've promised Pablo I won't say anything about Barcelona, so I'm not going to say how Barcelona's doing, but you can ask him afterwards. Let's see. This is okay. I could probably just spend my whole time talking about this slide. I have a few others, but this is really, I think, a continuation of previous presentations today. This is looking at prioritization. So this is a highly unscientific, not even very accurately comparative sort of two pie charts, but I've put them together. I'm using my right as the second to last speaker of the day to try to make a point. So if you look at sort of NCD mortality, we know it's 64% of all deaths. 80% of NCDs are in low and middle income countries. Cardiovascular disease itself causes 1/3 of all deaths, 17.3 million per year or thereabouts. And then if you look at last week when I was speaking to our emerging leaders, I used a 3% figure on the right-hand side for official development assistance for health funding for NCDs, which was 3%. That was the number that was established in 2008. So this past week, the Institute of Health Metrics and Evaluation report on global health funding in an age of austerity, which I commend to you all, said no, that number is actually 1.2%. So things have gone down, despite the high-level meeting and all those things. But I think really the result of the economy changing. This is again highly unscientific, but there to make a point. So does development assistance for funding, is that the final way to measure health and how we care about it and how we prioritize it? No, absolutely not. But it's certainly, I think, sets an important message that if the leading cause of mortality is 63% globally, and really roughly slightly less than that in low and middle income countries, but still quite high, and yet it's receiving somewhere around 1.2% of development assistance funding, official development assistance funding, then there's obviously a gap here. So that's addressing that gap, I think, is central to what we all do. It's central to why we all came together as I think the NCD movement in a way. While we all have represent diseases that have risk factors outside of the sort of traditional modifiable ones, we recognize that what we have in common far exceeds what separates us from cancer, diabetes, chronic respiratory, and cardiovascular. We have the 4 common risk factors. Obviously tobacco, unhealthy diet, harmful use of alcohol, and physical inactivity. But as NCD Alliance, because World Heart Federation is also one of the founding members of NCD Alliance, which has been a strong advocate for the high-level meeting, we said there's really almost a 5th risk factor, which is this gap, the low political prioritization, the low recognition of NCDs on the global agenda. I wish Jeff Sturcio may have left. He used to be head of the global health. Oh, you're there. Okay, I have to tell my Jeff story. So I used to, when I was at ACS as heading up global strategies there, and I used to submit abstracts every year to the Global Health Council meeting, and they would have titles like "Tobacco is going to kill 1 billion people," or leading cause of death, and sometimes they would be rejected. Sometimes they would give us a an afternoon session on the last day on a round table in a far corner near the kitchen, but there was never any plenary sessions. When Jeff came on board to Global Health Council, I said, no, you're there. You have to accept our abstracts. And he did. And he's gone on to do fantastic things in terms of helping all of us to prioritize NCDs. That's a highly unscientific example of prioritization, but it sort of does speak to, there was a mindset of NCDs aren't a global health issue. How could they be? Whereas I think we all recognize they are. So moving on, some of the drivers, again, of that imbalance, we know NCDs were not included in the original Millennium Development Goals, which led to a lot of donor prioritization. The myths had been persistent around NCDs being diseases that only affected wealthy people, largely men, largely old, in high-income countries. The changing markets, that's globalization, and metrics, again, absence of good data. I threw together those 4 M's. I was an English major in college, and I was kind of happy about those when I was doing these slides. So just a way of trying to understand why is it that NCDs have been so poorly understood. I think globalization has caught up with us. And again, also mortality and the success we've seen in allowing people to survive communicable diseases in childhood. So some of the rebalancing, again, the UN high-level meeting, the NCD approach, taking our commonalities, putting aside our differences, not always easy, but anybody who's lived through tobacco control knows if tobacco control advocates can all come up with common goals and messages, well, anybody can, because that's a motley crew. 25 by 25, which is the WHO mortality reduction, premature mortality reduction target, but which I think we also describe as the thing that finally you can wear on a T-shirt and sort of explain to people. NCDs are complicated, and the word itself is terrible. It starts with the word non. I don't go to the doctor and say I have an NCD. How do we, and what's the cause? Well, it's about 17 different things. It's a mix of how I've lived my life, and maybe I've had an infectious agent, a whole bunch of different things. But this 25 by 25 target, I think, is a little bit like 3 by 5 was for AIDS. It's something that is the next slide, we'll talk about it a little bit more. But it's finally something where we can, I'm dancing with this thing. We can finally mobilize resources. SDGs, yes, we're struggling to get a health goal. I think we will. Universal health coverage is having lots of political support. We'll do what we can with that, but we really do see that as an enabler. Would be much happier to see a healthy life expectancy goal. For us as World Heart Federation, we're really, again, mobilizing our own members around CVD leadership. I just had a fantastic meeting at lunch with British Heart Foundation. They're excited about being part of a global movement. It's something they haven't really engaged in before. So again, every single item here, other than the one in red, which is our own goal, are the WHO targets that were sort of debated and finally approved in this past World Health Assembly almost 1 year ago. And when I first looked at all of them, they were being sort of debated and worked over in Geneva at various meetings. I realized that the NCD targets are CVD targets. The NCD agenda is the CVD agenda, which is really interesting because we've had fantastic leadership from the cancer and the diabetes and chronic respiratory disease communities in the fight against NCDs. But they're all supporting this. They're all coming together to support targets that also affect their own individual disease groups. But really, everything here is almost like the strategic plan for a high-income country heart foundation in terms of this is what you do to address CVD. The only one that's less of a major issue is the alcohol one, but that still does factor into CVD. And we have the secondary prevention target lower left and the essential meds target as well. So we're really, for us as a CVD community, which doesn't necessarily have that much of a history of joint and cohesive advocacy, we're knocking on an open door here. We've got to get countries to support this, and we've got to celebrate the fact that we actually have very, good, some political, some evidence-based targets that can really help us tackle the CVD problem. The Global Action Plan, the WHO Global Action Plan, I commend all of you to read it. It's a great document, and it's one that we fully support. our feeling at World Heart Federation and within NCD Alliance is our role is to both support and challenge WHO, but we work alongside with them and work with them well. The 6 key pillars of the Global Action Plan, we believe, include things like supporting more research, and we believe are the way to get to success around the NCD agenda. And then there's a number of areas of sort of linkage between NCDs and HIV. I don't need to go into them. You've heard them all. But what I would say and ask all of you to do is to engage with us on advocacy. We're looking at how can we use the next set of political windows around further implementation of the 25 by 25 targets and the Sustainable Development Goals, and advocating for funding, all the things that come out of that, to secure funding not just for and political will, not just for NCDs, but everything across the health spectrum and an integrated approach. So this is just some examples of some of the synergies we've been trying to work with and closely comment on various HIV policy documents that are in the works as well right now. So there's many opportunities for linkages. The political declaration from the UN high-level meeting explicitly states that we must align efforts. The one other thing I would say that's I think important and relevant is the kind of donor funding we saw before. I don't think will come back. Nor perhaps should it. I think the funding will have the resources is perhaps a better way to think of it. There will be development assistance funding. We hope there will be more for NCDs, but we also need to think about the reallocation of existing resources, the repurposing of existing health systems. We need to think of governments taking this on themselves. I'm looking at Judith, who asked me to say that, but I was going to say it anyway. And we need to think about the costs, the benefits of coordination, so that you don't waste resources there. So by doing things together, we're as the NCD movement, we're not competing with each other. We're trying to align our efforts and have efficiencies and economies of scale. So I think that's, and being within an NCD movement, I think forces us to put aside individual agendas, at best it does, and priorities. But there are still also a number of existing platforms that we see as essential to this. Interestingly enough, the World Bank meeting last week, which was largely on UHC, there was a big focus on health systems strengthening, which I guess I was sort of cynical about that when I first heard about it, because I thought that was just the way that donors were trying to get away from saying they'll fund NCDs. They're like, oh no, we'll fund health system strengthening, sure. No, but it's a good thing. It's the right thing, but it doesn't lend itself to that kind of flash of success that has driven some donor prioritization. Health systems is a long game and one that it's hard to measure causality and sort of quick wins around, yet it's critical. The other piece, which is one of the reasons NCD Alliance and World Heart Federation have concerns about UHC, is so many of the issues lie outside of the health domain. So we could do a lot if we did tax subsidies for fruit vendors. We could do a lot more perhaps than we might with sort of just funding a health system around hypertension, as an example. Funding walking spaces. How do we do that in the big cities in the world? How do you go jogging in Lagos, as an example? And yet it's a must. You don't go jogging in Lagos, Peter says. No, you don't. And so what do we do there? How do we have access to physical activity? It's a big question mark, but it's a critical one, I think. So again, we're in an interesting time, and I think it's incumbent upon all of us to kind of come together around this. We as World Heart Federation have a really inaccurate equation on the upper right. 3 by 3 by 3 equals 25 by 25, which I don't think is actually correct. But we sort of have 3 strategies around global, national, and organizational impact. We have, as an example, we're trying to come up with common metrics for how we measure ourselves, with cardiovascular disease. We're American Heart Association has agreed to start measuring itself against 25 by 25, which is great, because then you start to have common reporting. And by common reporting, you can create some positive peer pressure across countries, and you can also start to really understand in better ways what works in different settings. And so we're very committed to the WHO gap. we are creating roadmaps around our priority areas. I'm very fortunate that Srinath Reddy of PHFI is our president and thus my boss, and I keep on pressing on this thing. But he's focused on tobacco, hypertension, and secondary prevention. Salim Yusuf of Pure fame is our next president, who is also continuing that focus around how do you get to implementation for the CBD community. So I commend, we'll be developing roadmaps, and I ask all of you to come visit our website and learn more about it, or reach out to me. And we'll be doing CBD roadmap meetings in Melbourne at our Congress, which Sally kindly mentioned. Lots of things going on in Melbourne this year. And we're working with WHO on these roadmaps so that we can come up with something that hopefully is useful and that we can take to governments. We are working with some of the Lancet NCD action group as well, so we can try to be as aligned and speaking from the same, singing from the same hymnal, as they say. So that is my presentation, and thank you very much.
Thank you very much.